Surprisingly, the rate of hospital infections, the risk per hospitalization has not changed substantially over the last 10 years. But the length of stay, how often people are staying in hospitals, has actually declined over that 10-year period. So on the one hand, people are staying for shorter periods of time, but the risk of getting an infection has stayed the same, which means that the risk adjusted for length of stay has actually gone up. The proportion of patients who get an infection, the likelihood that that infection is caused by a bacteria that is resistant to antibiotics has been going up steadily over the last 20 years, and certainly over the last 50 years, in fact. For instance, if one were to get a Staphylococcus aureus infection in the hospital, there's a 1 in 2 chance that that infection is MRSA, or methicillin-resistant Staphylococcus aureus, and is probably resistant to multiple antibiotics. And that's similarly true for things like Klebsiella, Acinetobacter, and other infections, other infection-causing bacteria. What we also do know is that if a patient were to get infected by a drug-resistant strain, they're much more likely to stay in hospital for longer. They're more likely to incur healthcare costs and also to die. So there's roughly a twofold increase in the risk of dying if one got the drug-resistant version of the Staphylococcus infection compared to the sensitive version of that infection. So that's a clear way in which drug resistance is contributing to the problem of hospitalization and infections, but also the other way around. As people get more infections, they get more antibiotics to treat them, and that in turn goes back to contributing more to resistance. So it's a vicious cycle. Changing the culture with respect to infections is obviously not easy. Different people have tried different things. There's been experiments with a concept called positive deviance. Others have tried using checklists to implement a specific set of procedures to reduce infections. So we certainly know a lot more about how to improve infection control today than we did about 10 years ago. What we may know a little less about is how to sustain those practices in the long term, and whether just implementing it once will result in a permanent shift in culture. What we also do know is that the incentives for infection control may not always be there. So while any individual clinician may want to make sure that their patients don't get an infection, and nurses may be doing the best job that they possibly can, the hospital as a whole may not bear the cost of infections, but it may bear the cost of infection control measures. Infection control may require having a full-time staff member, being the infection control nurse or professional. It may require specific investments in, caps and gowns, and having hand washing and other equipment in every patient's room. But hospitals may not always see the return on those investments, because even when patients do get infections, the cost of those infections may be borne by commercial insurers or Medicare or Medicaid. So a culture shift in the long term will necessarily involve changing incentives for how hospitals are compensated for infections. The responsibility really belongs to everyone. So hospital administrators have to set the right incentives in place, so they could have specific targeted payment programs or bonuses or rewards to specific wards or personnel who do a good job in infection control. But it's also the responsibility of every last healthcare professional working in a hospital to do a better job in infection control, for two reasons. One is to protect the patient, but second also to protect themselves, because it's also a workplace safety issue. And there's certainly also a huge responsibility for policymakers to ensure that the public safety is ensured by making sure that hospitals have the right incentives to spend the money on infection control. And certainly there's a lot more that can be done on that front than where we are today.